Okay, so we have two cases I want to go over. So this is patient case 1, 36-year-old woman, and a few of us have seen these patients. 36-year-old woman with IBS with constipation, bloating, vulvodynia, anxiety. She has bowel movements every other day, Bristol stool form scale type 2 to 3, type 2 being the constipation type. Pain is relieved with a bowel movement. She has stress-sensitive symptoms. She started her own architect business, which was stressful. She has a history of food allergies and eczema. Her physical exam is her BMI is 18.5. Her abdominal and rectal exam were negative. She had normal labs. Her vitamin D level was a little low. She was given vitamin D replacement. She was placed on a low FODMAP diet and had significant relief of her symptoms. But every time she tried to introduce like a little bit of a high FODMAP food, she had increased GI symptoms, so she just kept returning to her restricted diet. She was placed on disipramine to try to help reduce a lot of these increased abdominal symptoms that were likely due to visceral hypersensitivity, at least in part, but she stopped after 6 weeks because she got constipated, was placed on duloxetine, but took it for a very short period of time because she got nausea and dizziness. She was then placed on an SSRI because she had some anxiety and felt better with less constipation because it's going to cause less constipation. She uses over-the-counter magnesium, psyllium, and digestive enzymes as needed. She subsequently presented with a bright red blood per rectum, and the colonoscopy showed hemorrhoids. She saw our GI integrative health practitioner who talked to her about meditation, diaphragmatic breathing, yoga. She was also referred to a GI psychologist and underwent gut-directed hypnotherapy, but she only did it for a very limited time. She gets pelvic physical therapy for vulvodynia, which is helpful. She has fluctuating abdominal bloating and discomfort, which are her bothersome symptoms. Interestingly, her symptoms are better in the first half of her menstrual cycle. So this is before ovulation, this is the follicular phase. But it's worse in the latter part of the cycle, which studies have shown in the pre-menses, like a few days before their period again, they get worse symptoms. This is in healthy women and IBS and women with IBS. She still remains on a low FODMAP diet with the ability to only reintroduce small amounts of new foods. And we recommended reintroducing FODMAPs in a structured manner and really needs to go back to see Nancy. One thing I did tell her is, why don't you introduce the foods during the first half of your menstrual cycle when you're doing pretty well? A lot of patients, they can tolerate foods at certain times and other times they can't. Just to kind of increase the diversity of the food and hopefully the diversity of her microbiome. So this is an IBS patient on a prolonged restricted diet. Now, this has now been some years with persistent symptoms. And I know we've seen that because when low FODMAP diet was first introduced, no one really knew you were only supposed to do it for 6 weeks, up to 6 weeks. Now I think people know that, but it's hard for the patients the longer they've been on it, right? So Nancy, let me ask you, in which patients should we recommend a low FODMAP diet?
Yeah, so the primary endpoints with most of the studies that look at the low FODMAP diet are on abdominal pain and bloating. So those are the primary symptoms that we want to use if we're going to go for a full low FODMAP diet. We also, of course, want to make sure there's no eating disorder history, disordered eating patterns. If there are, we may want to consider a modified version of a low FODMAP diet or not consider a low FODMAP diet at all and instead work on bringing more foods in and maybe using the low FODMAP diet as a way to enhance the diet instead of reduce the diet. We also can use it to help with diarrhea. So as we mentioned before, these osmotically active agents can cause more looser stool. But again, with a constipated patient, we may want to keep those in and do more of a modified approach. And then there is some literature that it's helpful in celiac disease and IBD once they are in remission of those conditions. So we know that there's a high crossover rate of functional gut issues in those cases, about 40%, I believe. So that's when a low FODMAP diet can be helpful, but it should never be primary treatment for those cases. And then it can also be helpful for ostomy patients and SIBO possibly, but we won't go there.
Yeah, because there's like a SIBO diet, which is very different from this.
There's about 7 SIBO diets,
Oh, wow.
and no one has studied diet in SIBO. So there isn't actually a SIBO diet. There are multiple people weighing in on what they think could help. But when we look at AGA and ACG guidelines on helping with SIBO, they talk about the low FODMAP diet as helping with symptoms, not treating SIBO. It has nothing to do with treatment of SIBO. It's only to help mitigate those symptoms of bloating and abdominal pain. That's it.
So I just want to clarify, when you said to use it in patients with IBD, I think you said a celiac in remission. You mean that disease is in remission, but they have an overlap of
Right.
IBS-like
Exactly.
symptoms. Okay, yeah.
And I just want to put on my celiac hat here for 1 second. I think it's very important to know two things. When you're ruling out celiac disease, you really have to get an IgA level, not just the tissue transglutaminase, because 3 to 5% of the population is IgA deficient. I think it's also important before you think about instituting a low FODMAP diet, if you have a patient who has a lot of bloating, a lot of constipation, a lot of diarrhea, 10% of patients that we know because of the spectrum of celiac disease who have symptoms consistent with celiac disease on biopsy will turn out to have changes that are consistent with that diagnosis. And before you put them on a low FODMAP diet, you really may want to take the extra step to rule out celiac disease, because once they go on the low FODMAP diet, which is also gluten restricted, they don't want to go back.
And such good points. The other problem, at least we see, is a lot of these patients have self-prescribed a gluten-free diet. Right. So then it makes that diagnosis of celiac disease even tougher. And so sometimes we'll talk with the patient about fructan versus gluten. We can get them to do a fructan reduced but gluten challenge to then be able to check for the celiac disease.
Nancy, you have to give your pearl about sourdough bread.
Yeah. Oh, you want me to talk?
Yes.
Sure. Yeah, so what's nice, so fructan is the sugar that's found in gluten-containing products like wheat, barley, and rye. So we can actually use wheat products that are low in fructan to help keep some of these prebiotic-rich foods in the diet. And one way that we can help patients understand, because we know that it's a pretty small percentage of our IBS patients who actually have non-celiac wheat sensitivity or gluten sensitivity, it's more likely that they've got a fructan intolerance. And so we can test it by using sourdough bread, and we want to make sure we're using slow rise sourdough, so it needs to rise for at least 18 hours, have no added sugars or yeast in it, and we can systematically have them do small amounts to see if they tolerate it. Overwhelmingly, they tolerate it. And then we can say, well, look, this is actually high in gluten. I have celiac disease. I wouldn't be able to eat this. But because it's low in fructan, you can actually tolerate it. So now we can move into a different type of discussion.
I think that's really, really important. And Nancy, when you see a patient that's really on this restricted diet, and you mentioned RFID before, but what are some of the assessments we need to do, like some of the blood tests or vitamins? Is there a standard panel you would recommend?
I would want to do a diet recall to see so when I'm doing a diet recall with a patient like this, I'm thinking about all of the different groups. So are there any dairy products? Are there any beans and legumes? Are there any nuts and seeds, vegetables? I'm going through all my checklists, because then I can go, okay, they're probably missing some of the B vitamins, missing iron, they're missing fiber, magnesium. That's how I'm going through it as a dietitian. So I would want to go through their diet, see where there might be deficiencies, and then specifically run blood tests based on that. I would not recommend that we just blanketly run blood tests on a patient like this. I think we need to be more strategic in the way we go about it.
Okay. So Megan, when you see a patient and they have these fears of eating food, they're having a lot of trouble trying to bring back foods they want to, but they really struggle. And if they get a little bit of symptoms, they don't want to go there. How do you approach them? How do you communicate with them about this?
I mean, I think, first it's about why do they want to reintroduce? Oh, thank you. Why do they want to reintroduce the foods, right? So there's something that's limiting their life in some way. Usually it's like, well, I want to go out to eat socially again. I don't want to be a burden when we have to go, choose food groups. And so you always have to link, like, constantly verbally in these sessions and in these visits, like, this matters because it's going to free you up to do X, Y, and Z, right? And you want that back in your life. Because what happens is they're going to do something that's very effortful and is painful and it's distressing, right? So you're going to have to inoculate them that you will have some symptoms in the short term. And it's kind of like wading through the mud, and then you're going to get to the other side. So there's a lot of kind of walking them through that and getting them at least the intellectual idea around, like, this is going to be somewhat hard. Don't expect that, you're not going to have a reemergence of some of these symptoms that you don't want to, experience. And then I do a lot of, like, building distress tolerance skills. So what can you do to kind of soothe as you're doing this? And then really most importantly is the exposure. So very structured, gradual, and I have them help, define what that kind of hierarchy is of the food reintroduction. And so where they feel comfortable doing it. And then, ideally it'd be, can be in the office, but that's also like a safe kind of space as well. So a medical, clinic, a medical setting can also function as a safety kind of net for them. So you want them to do this in like generalized ways in their life as well, like in their own kitchen and then, going out to eat, things like that. But the very structured exposure is key.
Have you done that in your clinic visits where they bring some food and they're trying it out with you there?
Yes, but this was back when I was in Boston because it was pre-pandemic. So yes, absolutely, yes. Yeah, I had one patient, one of the difficult patients I've ever treated with IBS, and was so limited with food. I think she was only eating bananas and rice, and that's it. And yeah, I didn't get very far with her actually, but we did try to bring in different foods, and some of it was just smelling the food. So the olfactory kind of, just that alone is enough exposure to get them they already have a reaction to it. So it can be as what it seems as simple or as small as that, but that's actually part of the process.
I had a patient years ago who was at a restaurant and had a bad breakup. And he didn't want to go back to restaurants and thought that going out in restaurant foods increases symptoms. So I actually had him see Michelle Krask, who's the leading expert in anxiety. And as far as exposure therapy, what they would do is they would go to a restaurant and just sit there and eat. Don't order food, just to get used to being in a restaurant. And they would do that a few times, and then it was ordering a little piece of food, and then just kind of gradually, and then he was able to start eating food. It was kind of so interesting journey. So Nancy, I was thinking about this question too, but someone is asking it. Erythritol?
Erythritol.
I'm probably not. Okay, so that they use it to in stevia, a monk fruit extract, and there's been recent press about, I think, stroke, right? Yeah. So what are your comments on that?
So with stevia, I always go for the Rabiana A, which is the less chemicalized version of stevia, and I don't believe there's research on that having the same heart issue, but I just saw this on Thursday, so I haven't done all my research on it yet. I'm not gonna tell a patient they have to avoid erythritol, but I'm certainly not gonna recommend they go and buy a big bottle of erythritol and use it on everything, but it is deemed as one of the GI-friendlier sugar alcohols. So it is one that is allowed as part of a low FODMAP diet. So it's not like sorbitol and xylitol that really are problematic. Erythritol seems to be generally accepted. But again, I will push patients, if they're going to buy stevia to put in their tea or something like that, to go for the Rabiana A version.
The which one?
Rabiana A.
Oh, how do you spell that?
Oh, jeez.
If people want to write that down. I have stevia, and I looked at the ingredients, but it has nothing in there, so I can't tell what it has.
It probably is listed under the nutrition facts area. I can help you look. Lynn.
Yeah, so then I was worried about that. Okay. What FODMAP apps do you recommend? Because there's a lot of them.
Yes, there are. I actually don't recommend any of them generally to my patients because I think they can be either misleading or overwhelming. But if a patient seems like they've got a pretty good balanced view on diet, and I'm not worried about disordered eating patterns, the Monash app is the only one that really is current. The problem is that it can be a very overwhelming experience for a patient because it's taking it down to teaspoons and tablespoons and 14 blueberries, now it's 12 blueberries, now it's 10 blueberries, okay, we're back up to 15 blueberries are allowed. So practitioners use it, and it's very helpful for us, but I find giving patients, we've got a 6-page handout on just brands. We've got multiple links for different recipes. I find that works better to give patients those types of resources than to have them. Also, the Monash app costs money. It's nice because it auto-updates, you pay once and it's done, but a lot of the other apps are not keeping as up to date as I would like them to be. So at this point, I don't really recommend apps.
Okay, so before we go to the net, we have one more case. I want to answer one question around TCAs. Many times patients are often taking one other psych medication like SSRI. So how do you put that together? So you can use an SSRI with a low-dose tricyclic agent. So you can use the normal dose of a SSRI like 10, 20 milligrams and use 20 to 50 or 75 milligrams. The main thing you have to think about, because a tricyclic is also a serotonin reuptake inhibitor, you have to think about serotonin syndrome, like tachycardia and sweating. So those are some, but usually you do not see it in low-dose tricyclics with a regular dose SSRI. The only thing that happens with that combination is the blood level of the tricyclic could be a little higher in the blood, but it isn't substantial. I don't know, maybe you don't only need 20 instead of 30 milligrams of to disipramine. Okay, we need to move to the next case. A 40-year-old gentleman with a history of a GI infection in 2002 when traveling in India and was in bed for a week. He had bloating, nausea, vomiting, fever, non-bloody diarrhea, was treated with antibiotics, and since then he's had irregular bowel movements. He's had tiredness, chest pain, had a negative cardiac workup, bloating, and distension. This all happened when he was in India for a very, very stressful trip because it was personal. Like there was some personal pressure placed on him. And then he also had work-related stress. Notable triggers of his bloating were stress, physical activity, caffeine, pears, and few other foods, and a lack of sleep. He consumes a vegan diet. A reduction in dairy products improves symptoms. Tried a low FODMAP diet for a few weeks with little relief. Tried digestive enzymes and probiotics with no effect. His physical exam, BMI 25, it's normal. Routine labs, fecal calprotectin, celiac serology is negative. Breath tests for SIBO was negative. He took ciprofloxacin for a sinus infection, which he said improved his symptoms. He felt better for several years after he took a leave of absence from work to begin a startup. Then during the pandemic, he was living at home, he was running more regularly, and he felt well. Then during this time, eventually he started investing in the stock market. And because he had a startup, he had to move in with his parents and was also investing for them as well. So in mid-2021, he started noticing worsening bloating, distension, loose stools with exercise. So now he felt like he was limited in exercise when he was able to do in the past. Daily bothersome bloating occurs as soon as he wakes up, gets worse throughout the day, worse with eating, worse with exercise. He gets distension. It causes a pressure in his head, chest, paresthesias in his legs and arms. He has heartburn, takes a PPI. He has multiple cardiac and neurologic evaluations, including a brain MRI, which were negative. Had these diagnostic studies that you can see here, no H. pylori, had random biopsies in his bowel, and everything's negative. He used FD Guard, IB Guard, provided some partial relief. He used this Indian herb that helped to reduce bloating. Also used a Chinese herbal powder mix that helped to normalize his bowel movements. He had gut-directed hypnotherapy with some improvement in symptom-related anxiety. He saw our GI integrative health practitioner who recommended mindful eating, diaphragmatic breathing, and also positive health behaviors. So we want to talk about a case where you're managing DGBI with coexistent psychological disorders. This person has post-infection IBS with persistent abdominal bloating, distension. He has stress-related symptoms with GI symptom-related anxiety. There's a lot of hypervigilance, a lot of attention to his symptoms. And then this trying to institute a integrative care approach with diet, medications. Mirtazapine was added to help with the reducing the abdominal symptoms, would treat the anxiety as well, improve his sleep. So this is a lot. So I really want to ask Suzanne, who knows this patient, and also Megan, who doesn't know this patient, but her approach too. But Suzanne, do you want to start off?
Yeah, so when I met with this patient, his main bothersome symptom to me was the abdominal bloating and distension. And so earlier you had said I talked to the patient about this, but actually I don't only talk to the patient, but we actually do these practices in the visit. So one good thing, right, also I want to plug about still being able to do some telehealth is you have patient in their house, right, where they're comfortable, and I can have them in the place where they're making that neuro association to do the practice, because this is important with him. So we're doing the breathing, and he's just can't relax. He just isn't able to relax. So I suggested let's recline, let's lie down on the bed, and he's complaining of distension at this moment, and so we started doing it, and he couldn't believe all of a sudden his distension is just going away right in front of his eyes. Because we have to remember, right, that the diaphragmatic breathing is a mechanical process as well, right, to coordinate the diaphragm, the abdominal muscles, the pelvic floor, as well as, dampening the signals from the nervous system. But, okay, so feels okay, then cancels the next appointment because he hasn't been doing the breathing. And it was just kind of clear to me that this patient had anxiety. And yes, he has all these other symptoms, but to me, I was seeing that this anxiety was driving a lot of his symptoms. And he did okay while he was with me, and even with the hypnosis, the gut-directed hypnosis, he could get relaxed, but he just needed more support on an ongoing basis, in my opinion. Yeah.
So Megan, fortunately, even though you're focusing on GI symptoms, you're very good at managing comorbid psychological symptoms. And what is your approach in this patient? And also, maybe the situation of when do you refer to a general psychologist dealing for general anxiety or psychiatrist, and just give your take on this.
Yeah, and I think if I remember with this patient, there was a lot of just like health anxiety, like some like physiological anxiety, right? About any kind of physiological change. Okay. Yeah.
Well,
so
if he would lay down on his stomach,
Yeah.
he would get these like nerve symptoms and palpitations. But then if he didn't lay on his stomach, then he didn't have it. So it was very like, what the positioning was bothering him.
Yeah. So these are, I mean, just from brief review of this, I mean, it just seems like very high neuroticism, right? So that's like a personality kind of style that's harder to treat, but you can treat it. So there's kind of state anxiety and trait anxiety. So I would go into it with that approach, like, okay, that this is going to be, first of all, if I were seeing this patient, it's going to take me a lot longer to treat this patient. And it's treatable, but then we have to decide, do they need to go to a different psychologist? But that psychologist would be treating some version of health anxiety, or what we call anxiety sensitivity, where there's like that physiological component of any kind of physical change. But I think in general, like so the hypnosis is working, like the relaxation, like that kind of being able to let go, even in the hypnosis, is actually interesting that he could engage enough to have that feeling of letting go of control, because a lot of people are just pretty resistant to that when they're that anxious. But what I would have to do is get really behaviorally specific with him, like why, how can we apply this in your day-to-day life? So you said that he wasn't able to kind of generalize it, right, into his day-to-day life. So how can he do this on his own independently without a therapist or a nurse practitioner delivering that intervention to him? So that's like the key gap, and I would highlight that with him, and have him come up with ways to do this, and explain exactly why we're doing this, like what the rationale is and why it has to be so behaviorally specific, and then what his mind is going to tell him about why he shouldn't be doing this. So, you do a lot of work on the cognitive stuff, because his mind is going to come up with, I can't tolerate it. Oh my gosh, this is going to be like, why is this happening? Now I feel this thing, and just his mind is just going to spiral and spiral. So you have to do some of that work, like preemptively while you do this. But it would take longer, definitely take longer for this treatment.
Yeah, it's really making the patient feel safe and empowered.
Yeah.
Lucy, do you have comments about this case? Because I'm sure at Mayo Clinic you've seen a fair number of these patients.
Yes, not particularly, but trying to think. I mean, I think all of the points that have been made have been excellent ones.
Okay. So Ellie and Wendi, since you're going to be in independent practice soon and you have your 30 minutes or 15, is there anything that you want to bring up or even ask your colleagues here of advice of how you manage someone like this in the limited time, and what, as a gastroenterologist, we can do? While we're going to refer to others, but are there thoughts in your mind of what you want to, information that would be helpful as a gastroenterologist?
I think with a patient that has a lot of generalized anxiety and a lot of symptom-based, I think I find it difficult in clinic, where I personally won't be won't even be able to ask a question. So they just go on and on about their symptoms. So I find that part the most challenging. And I've learned in Dr. Chain's clinic to kind of redirect the patient and kind of ask them about, symptoms that bother them the most, and hopefully redirect their attention that way. And also I like to ask patients, are they even interested in, behavioral therapy or dietary therapy? Because if they don't have the buy-in, I find that very difficult to refer the patients as well. But
I think I find like active listening is also very helpful. I think a lot of these patients have so much anxiety and fear, and they feel like nobody's listening to them, and everyone's ignored their symptoms. So I think a lot of it's like, yes, I know this sounds really terrible. This must be very difficult to go through. And sometimes people are like, yes, it is. Like nobody has realized that. So I think that is really important in building your provider-patient relationship.
Which is therapeutic. That's the
Yes.
therapeutic part, is listening.
I think my question is sometimes we are practicing in resource limited settings. So if we don't have access to a GI psychologist or a health practitioner, like what can you recommend for our patients in those settings?
That's why I was bringing up the digital apps. So Megan, do you have one you would recommend to, I know we have to out of time, of the gut-directed hypnotherapy apps versus the CBT apps?
Oh yeah, that's a hard decision. So first of all, I do think they're highly underutilized. So it's something that, there's 2 out there that you can prescribe right away that are FDA cleared. And so these have very rigorous evidence behind them. The other thing for the buy-in, right, I just want to go back to that around the behavioral therapy or like stress management or dietary therapy, is to talk about the evidence behind this, that we know this is as effective or can be as effective. And so it's not just kind of like this nice to have and it make you feel good kind of a thing. I think that that's very important. So the digital behavioral therapy apps, actually I was just thinking about it for this case too, he might be somebody who would really benefit from it because you always have it with you and you can go in and use those practices right then and there. And it's not, you don't have to rely on the therapist session to do it. So that could be helpful. I think the only, in terms of if it's gut-directed hypnotherapy or CBT, I think there are 4 or 5 out there that, we can provide a list if people want it. But the only contraindication I really know of is if there's kind of active PTSD symptoms, which, you're likely not to even find out in a 20-minute visit with the patient. You'd rather go with like a CBT version. And I also think like multimodal therapy, even doing both, it could be fine, or they can decide. But if somebody's gonna have a very hard time with behavior change, because again, it's not fun. To do the hypnotherapy first is nice because you do just listen. So you can just lay back, put the headphones in and listen, and it feels less effortful.
Yeah.
So that's one thing to consider.
Okay, so we're out of time. I'm going to answer this last question about acupuncture. There is data to show that acupuncture, if you compare it to sham, is not effective for IBS. It's the patient-provider relationship that's important. There is data to show that acupuncture is effective for chronic constipation, though, and I'm sure there'll be more studies out there about acupuncture as well. So I really want to thank our panel and speakers and all of you for your attention. I hope this was helpful.